Obviously, every one of you must be thinking, there is glaucoma and there is intraocular pressure. And why am I talking about things like non-IOP risk factors? But there is a reason to it all. Why are we thinking of this today is because we all do know that elevated intraocular pressure means glaucoma. But that is actually an old thinking. There is actually a need now to identify the real pathology. Is there something that is still eluding us? Do we already know things that we can change? And that is what we're going to look at today. So IOP is a relatively big risk factor in glaucoma. That is very well understood. But look at this slide now. It tells you that you can have a normal IOP with no glaucoma in the normal population, and you can have a normal IOP in normal tension glaucoma where there is glaucoma. Similarly, you can have no glaucoma with high intraocular pressures as an ocular hypertension, and you can have glaucoma present in open angle glaucoma with high intraocular pressures. We've all seen patients well on their target continuing to progress. Why does this happen? Is our target wrong? Are the patients not compliant enough? Are there other factors? And if so, how do we identify them? Obviously, any patient who is progressing needs further attention. Look into compliance in detail, because many times when they come to you, they have this white coat syndrome and they have their drops well on place, but otherwise they don't use their medications as has been prescribed. And so though when you see them, the pressure is on target, the pressure is really not on target, and they're continuing to progress. Look for intraocular pressure fluctuations, because you're only seeing a very minuscule amount of the pressure, whereas the same intraocular pressure deals with that eye for 24 hours, and you're just taking a few seconds to measure this pressure. Look at the cause for fluctuations. And there are many simple things that you can do. Is there a fluid overload? Could it just be a tight collar? An executive at work goes very formally dressed with a very tight tie, and that could raise his intraocular pressure. Could it be a periodic breath holding, like musicians who use breath holding to play musical instruments? So what do we really need to ask for? We need to ask them history, and history of systemic hypertension is one of the most important things that we need to find out. We also need to find out the current treatment that they're using for the systemic hypertension. Other than that, we need to find out what medications are they taking, especially if they are steroids. They could be systemic, inhaled, topical, or nasal steroids, and all of these can actually elevate the intraocular pressure. Then you've got to think of compromised ocular perfusion. So you have diseases like the Raynaud's, like sleep apnea, syncope, hypotension, acute blood loss with transfusions, which could all give rise to a compromised ocular perfusion. And neurologic symptoms like headache, weakness, dizziness, diplopia, or loss of consciousness. All of these and more can actually lead you to what you need to know. So other than intraocular pressure, is there something else? Yes, and I've just said that we have to look at all these things. So you have to look whether the patient has suffered from a major blood loss, as this patient has had long periods of ocular ischemia. And there are a number of randomized clinical trials which have looked at non-IOP risk factors in glaucoma, which cause progression. So we have the OATS trial, the early manifest glaucoma trial, the advanced glaucoma trial, and the normal tension glaucoma trial. And they have identified many factors: low perfusion pressure, age, central corneal thickness, cup disc ratio, pattern standard deviation on the visual field, presence of pseudoexfoliation, disc hemorrhage, and vasospasm. Now, if you see that age and disc hemorrhage has been marked as red, because those are the things that 3 trials have found to be in common. But we have to look at other factors that cause glaucoma. So what are these other factors? There are 2 major things that you have to look for: an autoregulatory dysfunction, which can be because of ocular perfusion pressure, which is not normal, the intraocular pressure, which is not normal. You could be looking for an ocular blood flow, and all this could result also in an perfusion instability, which could be even enhanced by an ischemic insult or by a reperfusion injury. Both of these in turn lead to a retinal ganglion cell, which finally moves on to glaucoma. So vaso-autoregulation, what is that? It helps to meet the body's needs, and it is tailored to meet fluctuating local metabolic demands. So for instance, if you've had your lunch and you had a heavy meal, all the blood supply is then obviously sent towards the digestive system. And the vascular tone maintains appropriate levels of the hydrostatic pressure, avoiding edema. Regulation is mediated by three phenomena. You have the autonomic nervous system, you have the systemic hormones, and you have local autoregulation. Now, there are two types of stimuli for local autoregulation, which are myogenic and metabolic, and these can induce a response from the local vasculature. So the metabolic demand or supply can increase or decrease, which modifies the perceived need for oxygen and nutrients. And that is how you can either get an increase in your blood supply or decrease in your blood supply. Metabolic factors can then alter the vascular tone. What happens when we talk about a myogenic stimulus? Now, as the blood flow increases, the smooth muscle cells of these vessels are stretched. This opens the calcium channels. With an influx of calcium, the muscle contracts. It reduces the lumen of the vessel and reduces the blood flow. This is what happens in a normal individual. However, several studies have shown this autoregulation to be deranged in glaucoma, and this could be due to a dysfunction of the endothelial factors responsible for maintaining the vascular tone. Impaired autoregulation results in altered oxygen being supplied to the ocular tissue. If the oxygen supply is reduced, there would be an ischemic damage. If the oxygen levels are increased, then it could lead to oxidative stress and cell damage. Now you have to know that there is something which is known as a constant ocular perfusion. And what is this constant ocular perfusion dominated by? So there is a definite systemic relation between the systemic hypertension and hypotension. There is a regulation of the vascular blood flow by vascular tone mediators and the intraocular pressure. Changes in any of these can result in a cellular damage, in apoptosis of the retinal ganglion cells, and tissue remodeling, resulting in glaucomatous optic neuropathy. Systemic hypertension, we know, has a positive correlation between intraocular pressure and the systolic pressure. Chronic hypertensives may have microvascular changes and impaired blood flow to the optic nerve head. Ocular blood flow is dependent on the ocular perfusion pressure. Now, what is ocular perfusion pressure? It's very easy to calculate. It's just 2/3 of the mean arterial pressure minus the intraocular pressure. Therefore, when the intraocular pressure increases or the arterial pressure decreases, obviously the ocular perfusion pressure is going to reduce. When the diastolic ocular perfusion pressure goes below 50 millimeters of mercury, this increases the risk of incident or progressive open-angle glaucoma up to 5-fold. Patients with nocturnal hypotension are also known to progress. And in these patients, it's very simple. All you need to do is get back to their physician, and if you can change their systemic medications so as to not have this nocturnal hypotension, but at the same time have a good control of their hypertension, that will help us in maintaining a good ocular perfusion pressure even at night. Now, the reduced ocular perfusion pressure is because of many things. You can have a reduced CSF pressure because of the biomechanical properties. You can have an increased intraocular pressure. You could have a decreased blood flow, all of which could result in a reduced ocular perfusion pressure. All of this leads to a primary insult. Now, in the primary insult, the RGC mitochondria are mildly affected, and therefore the RGCs are now at reduced energy levels. This leads to a secondary insult, and that finally leads to the RGC death. Now, the reduced ocular perfusion can also be because of abnormal neurovascular coupling or abnormal autoregulation, and that in turn also again leads to the RGC death. Let's look at this case. This was a young 35-year-old patient who came with a history of a sudden fall in vision. This patient had a CRVO in one eye with a high intraocular pressure in both the eyes. This patient was treated for his CRVO, but his glaucoma was progressing despite being on maximal medical therapy, and his IOP was in the low teens. So what do you think could have been the cause? He was progressing. I was wondering what to do with this patient, but I just thought that let me look at his ocular blood flow. So we got a carotid Doppler done, and that showed us a plaque of grade 3 to 4 in the common carotid artery at its bifurcation. There was a thickened intima in the common carotid artery, which was suggestive of atherosclerotic changes. There was a low velocity flow noted in the left vertebral artery, and an ocular color and spectral Doppler suggested an occlusion of the left ophthalmic and the left central retinal artery, causing a left-sided ocular ischemia. And so we knew that was probably the reason why his left glaucoma continued to progress despite being on the correct therapy. Now, reduced ocular perfusion, blood flow velocities, and or altered resistivity index could be a predictor for glaucoma progression. Color Doppler imaging is a good modality for the imaging and the hemodynamic study of the optic nerve vessels. It may help in facilitating the understanding of the pathogenesis of glaucoma. What we may do is probably introduce blood flow measurements into the clinical practice for diagnostic and follow-up glaucoma disease. This could also help in the care of the patients of glaucoma where nothing else works. Patients with migraine have a higher intraocular pressure, and patients with normal tension glaucoma have a higher incidence of migraine. Migraine is vasospastic despite having a neural origin. Vasospasm may be related to endothelium-derived vasoactive factors. Both Raynaud's and migraine are associated with an increased endothelin-1, and so also is normal tension glaucoma. Now, this is a case of a 40-year-old female patient who initially presented for a headache, was diagnosed to have a primary angle closure glaucoma in the right eye and a primary angle closure in the left eye. So she underwent a peripheral iridotomy in both the eyes, and she needed to be on topical anti-glaucoma medications even post her iridotomy. Her episodes of headache lessened, but they did not really subside, but her vision continued to fall. She was developing lens changes. A repeat gonioscopy showed that there were peripheral anterior synechiae in the right eye, but the left eye was very wide open. So I did all her parameters. Her anterior chamber depth seemed to be okay. Her lens thickness seemed to be okay. The IOP was well controlled, but the disc in the right eye continued to worsen. And the perimetry in the left eye was within normal limits. There was on the overview in the visual fields, the right eye showed us a progression. Sorry. We found that there were episodic attacks of headaches with an aura. The attack lasted for 24 to 30 hours. It was always associated with photophobia. Sometimes the attack was aborted with drugs. A diagnosis of migraine was made, and she was treated for the same. She's being monitored on a regular basis, and it took us 6 months to see her perimetry did not change repeatedly on 3 visual fields. Thereafter, her visual fields have been stable for the last 3 years. The cause for progression was probably migraine. Now, cerebrospinal fluid pressure suddenly gained a lot of importance in the last decade. Retinal ganglion cell damage occurs at the level of the lamina cribrosa. Yet, we measure the pressure differential across the cornea. So patients with open-angle glaucoma and normal tension glaucoma have lower CSF pressures, whereas patients with ocular hypertension have higher CSF pressures than controls. So the translaminar pressure difference, that is the intraocular pressure minus the cerebrospinal fluid pressure, may actually be a more relevant risk factor than the transcorneal pressure difference. But how can that be measured? Even less likely modifiable is something that we have to still think of. Now, here is a 68-year-old male patient who was diagnosed with normal tension glaucoma, was on a prostaglandin analog. He presented with a disc hemorrhage in the right eye. Perimetry done 4 months later showed a query progression in the defect. Now, this is the fundus picture. Very clearly, you can see the disc hemorrhage. And it took us 4 months to find out that there was progression. So disc hemorrhages are considered a sign of ischemic optic neuropathy in glaucoma. Hemorrhages are located either at the superior or the inferior poles and may be flame-shaped or splinter-shaped. It increases the risk by 3 to 6-fold, indicating the need for more aggressive intraocular pressure reduction, particularly in the older patients with significant normal tension disease. Many studies have linked progression with disc hemorrhages. The CNTG found it to be a major risk factor, and in addition, the disc hemorrhages are also associated with progression in all 3 variants: primary open-angle glaucoma, primary angle closure glaucoma, and ocular hypertension. Now, diabetes is also a vascular risk factor as it is a microvasculopathy. Probably it results in non-perfusion and angiogenesis. How it affects glaucoma is controversial. It may lead to vascular damage to the optic nerve head and the retinal ganglion cells, making them more susceptible to damage. It could cause changes in the trabecular meshwork as well. Sleep apnea is something else that we have to learn to look at. Obstructive sleep apnea is a chronic condition leading to apneic periods with hypopneas, and respiratory arousals are an emerging risk factor for glaucoma. According to the Wisconsin Sleep Cohort study, the incidence is from 2 to 4%, known to be associated with systemic hypertension, cardiovascular disease, stroke, and abnormal glucose metabolism. Obstructive sleep apnea is associated with many ocular pathologies. 10% of patients with obstructive sleep apnea have glaucoma, and 50% of normal tension glaucomas have OSA. Also associated with floppy lid, CRVO, worsening of retinopathies, both hypertensive and diabetic, may have papilledema and NAION. Sergi et al. Found that severity of OSA correlated with the intraocular pressure, the mean deviation in a visual field, the cup disc ratio, and the mean thickness of the retinal nerve fiber layer. Metabolic and vascular changes resulting from excess carbon dioxide superimposed on the endothelial damage due to hypoxia, and that is probably responsible for glaucoma. So how do you diagnose a patient with sleep apnea? Normally, the patient is obese. He has a large neck circumference greater than 40 centimeters, is tired even on waking up, snores during sleep, and wakes up in the middle of his sleep quite often due to respiratory distress. So sleep labs do sleep studies like nocturnal polysomnography and diagnose sleep apnea by the apnea-hypopnea index. If the AIHI or the apnea-hypopnea index is greater than 15, then the patient is supposed to have moderate sleep apnea, and anything between 15 and 30 is severe. The treatment is very simple. You just got to refer this patient obviously to a physician who will then put him on a CPAP. If there is a local obstruction, then there could be a surgical removal of that airway obstruction. Increased blood viscosity is also a risk factor. It leads to decrease in blood flow and stasis in the capillaries. This in turn leads to hypoxia, commonly seen after an unusually large blood loss, sometimes seen in patients after a CABG. Now, here is a 52-year-old male patient who is diagnosed to have POAG, who started a treatment. He was very regular with treatment. IOPs on medication were well in their teens, but patient's perimetry was seen to be progressing despite this. His blood pressure was normal. He was very compliant. He was not obese. He didn't have any diabetes. He was an athlete. And in the last year, he had started doing yoga. He started doing Shirsasan every morning. And on a diurnal, his peak IOP was 28 to 30 millimeters of mercury. So diurnal variations of intraocular pressure have found to be a big risk factor for progression. Asrani et al. Have shown patients with higher fluctuations to progress more rapidly. The AGIS has also proven larger diurnal variation in IOP increases the odds of visual field progression in eyes with a low mean intraocular pressure. This is another case of a 65-year-old female on treatment for POAG, very compliant with therapy, continued to progress despite being on target at every visit. She used to actually use an alarm to use her medications, and her IOPs were always ranging between 14 and 16 millimeters of mercury. But a diurnal showed a peak at 7 a.m. and that was 24 millimeters of mercury. On detailed history, She used to drink large volume of water on getting up. So as we have seen to start with, there are many risk factors that have been actually identified by these various randomized clinical trials. So to conclude, there are many of these above risk factors which just cannot be changed. For instance, you can't change the patient's age or his corneal thickness or his existing visual field damage, or if he has pseudoexfoliation or a disc hemorrhage. None of this can actually be tackled by us. So then what can we alter? We can definitely alter his ocular perfusion pressure. We can look for obstructive sleep apnea and treat it. We can look to see whether there is vasospasm, which is causing progression of his disease. If he is a hypertensive, we need to treat his systemic hypertension correctly and make sure that he is not going into nocturnal hypotension. We need to stabilize his diabetes, and we have to prevent his IOP fluctuations, sometimes by going into very detailed history, by finding out if he has fluid overloads, if he's using breath holding, if he uses certain postures during exercise. So to summarize, various risk factors have been investigated in glaucoma. Every risk factor is complexly linked to each other. IOP-related mechanical stress, BP-related vascular stress, and disturbed autoregulation are complexly linked to each other in the development and progression of open-angle glaucoma. Daily repetitive ischemia reperfusion insults to ocular structures might also play a role in the vascular pathogenesis of NTG. All in all, we've looked at so many risk factors, and there are a few factors other than intraocular pressure, which we can all definitely intervene at different times if you find that your patient with glaucoma is progressing despite being on his target intraocular pressure. With this, I would like to thank all of you and remind you that a nation's culture resides in its heart and the soul of its people. And during this crisis that we are facing, I hope all of us therefore just stay put, stay home, stay safe. Thank you.
Thank you, ma'am.